Welcome to use of CT for pediatric trauma. I'm looking forward to discussing some cases with you. And as was mentioned, we'll be talking about reasons why you would want to use CT in trauma cases. We'll talk a little bit about CT protocols and radiation safety. And then we'll also go through some cases and talk about critical findings on pediatric trauma CTs. I have no conflicts of interest. So when we talk about imaging in pediatric trauma, in pediatric emergency in general, our first line imaging is typically going to be X-ray. So X-ray is the majority of the type of imaging done in trauma. We may also use ultrasound, which is no radiation, and so is often preferred in pediatrics. This is an example of a child with a small abdominal wall defect and some fat herniating, perfect with ultrasound. CT is used sparingly, only when needed, and so that's going to be the focus of our talk today. So this is the higher radiation exams that we might use. Fluoroscopy is not as commonly used, but it may occasionally be used, such as in this example of diaphragmatic paralysis from the literature. We're not going to talk about fluoroscopy today. And finally, MRI is very rarely needed in trauma cases, but occasionally is needed, most often for a spine injury, where we're looking for something in the spinal canal that we can't see with CT or other modalities. So as an overview of the types of imaging you might encounter in pediatric trauma, there's a wide range of things that we do, but CT is really the way that we evaluate kids who may have serious injuries. So we'll talk about that. So why don't we just CT everyone and get all the information that we need? Well, it's because of radiation risks is one of the reasons why we don't just CT everyone. So as I'm sure you know, children have a higher risk of future cancer development from the radiation that we administer. And this is for two main reasons. As growing bodies, they have more dividing cells, and those dividing cells are what are susceptible to radiation damage. Children also have a longer lifespan over which to develop cancer. Cancer development following a radiation exposure is a long-term process. So children who have decades and decades over which to develop those cancers are going to be at much higher risk than someone who's 70 or 80 and is unlikely to live long enough to develop a radiation-induced cancer. This graph shows you kind of where the risk lies in age-based form. So kids who are 10 and under, you can see have a very, 20 and under, population who are 20 and under have a much higher risk of lifetime induced cancer from radiation. So this is why we are cautious with CT in children. I'm going to talk a little bit about how the trauma patients are evaluated before they come to us in radiology. And I realize some of you on this call are much more expert at this than I am. So hopefully I don't lead you astray. But we think about trauma when patients are coming in to us in terms of the level of trauma, the severity of the trauma. So there are guidelines from the American Trauma Society and the American College of Surgeons that describe both the level of care needed and the capabilities of the facility providing care. So these go from level 1 to level 5, level 1 being the most intensive care needs, and level 5 being something that's very low intensity and can be managed at a hospital with less resources. So a community hospital where they may not have pediatric surgeons on site, whereas a level 1 would need complete pediatric surgery and rehab care. As an example of a level 1 trauma, often you'll have multiple body parts involved. So level 1 traumas are almost always going to get some kind of CT imaging. This is a 14-year-old who was involved in a rollover motor vehicle collision. And so you can see that on the abdominal CT, we have a shattered spleen with extensive lacerations, a large perisplenic hematoma, as well as blood in the right upper quadrant too around the liver. So severe intra-abdominal injury. This child also suffered bilateral acetabular fractures, a focal pulmonary contusion, and then you can see, of course, in the head that there's large hemorrhages that are probably the most concerning thing about this trauma. So a level 1 trauma is typically going to get some kind of CT, if not a CT of kind of everything. We also can talk about the injury severity score. This is less used in the immediate care scenario, but is used to help describe injuries in terms of research, epidemiology, and hospital resources. The injury severity scores divide injury into 6 body regions: head and neck, face, chest, abdomen, pelvis, extremities, and then other. And so this is a scale from 1 to 6. And it's weighted, so the score is calculated by squaring the scores for each body part. We don't see this as much, in our clinical workflow, but it's helpful to know about when you're thinking about policies and when you would want to CT kids. So the trauma scales and the injury scales are things that we use to assess the severity of injury. But the question that we're interested in this talk is who needs CT? And for that, we go in large part to the research network, the Pediatric Emergency Care and Research Network, or PECARN, which is a network of pediatric emergency care, emergency medicine specialists who do large-scale multi-institutional trials to understand how care is being delivered and how it can be best delivered on a large scale. So these studies tend to involve tens of thousands of cases. So for head CT, we have PECARN guidance, and it's broken into 2 age groups. So kids younger than 2 years have sort of a different algorithm than kids older than 2 years. And what we see is that for those who are most severely injured, which would be defined by an altered mental status, a GCS of less than 15, or a palpable skull fracture, those are kids who definitely need a head CT. It's recommended. You then have a sort of in-between group where there's clinical judgment. So if a patient has a loss of consciousness more than 5 seconds, a non-frontal hematoma, is not acting normally, or has a severe mechanism of trauma. And that's shown by this graphic here, mostly involving motor vehicles or falls, or being, the recipient of a fall of a heavy object, being struck by a heavy object. Those things may warrant CT, but there's some clinical judgment involved. Outside of these criteria, CT is not recommended or not required. So that's a guideline that can help lower radiation by not doing CT in kids who have a very, very low likelihood of having anything useful on the CT. As an example, here is a 5-week-old who came into the ER with a GCS of 3. And so we see a significant amount of intracranial injury. We have subdural hemorrhage along the falx, as well as in the right frontal space. And we see the midline shift to the left, as well as complete effacement of the right lateral ventricle. So very severe intracranial injury. It's helpful to know that intracranial hemorrhage or mass effect, which can result from the hemorrhage in infants, may present as seizure or abnormal eye movements, which is, I think, a bit different than the way you may think of it in adults, where it may present with headache or focal neurologic signs. In infants, it's often nonspecific seizures and abnormal eye movements. So in kids older than 2 years, we have similar criteria for those who need head CT. So altered mental status, a GCS of less than 15, or signs of basilar skull fracture. And because these kids typically can give us more of a history of what's going on, we look for history of loss of consciousness, severe headache, and again, we think about the mechanism. Outside of that, again, CT is low yield and not recommended or required. Here's an example of a child older than 2. So this 14-year-old hit their head on a pole, and we see, again, right extraaxial hemorrhage here with some midline shift and a small amount of mass effect effacing the frontal horn of the right lateral ventricle. So this is a level 1 trauma, which did need total care for this injury, including surgery and rehabilitation. Spine trauma. I'll pause for a minute here. Did anybody have questions on what I've shown so far on the head imaging? Okay, and I can't see the chat, so at some point somebody can let me know if there's any questions in the chat.
Yes, I'll let you know.
Okay, awesome, thanks. So spine trauma, we again have some guidelines from the PCARN groups. So this is a little bit less definitive than the head injury guidelines. So we have categories of consider CT versus consider X-rays versus consider no imaging at all, just using clinical assessment. So the category that falls under consider CT actually sounds fairly severe to me, and I can't imagine somebody would not CT these children. So with a GCS of 3 to 8, or the AVPU scale, which I wasn't familiar with, but maybe used. So this is rating whether the child is alert or verbally responsive only, responsive to painful stimuli only, or unresponsive. So a 4-point scale of how responsive the child is. Abnormal airway, breathing, circulation, or focal neurologic deficits. Those are conditions in which you might consider a spine CT. I think you would be certainly justified in getting CT in those patients. The small and long-term theoretical risk of radiation is definitely outweighed by the risk of the patient's injuries and the need to characterize what's going on anatomically. So kids where you might consider X-rays rather than CT would be those with a GCS of 9 to 14, who are verbally responsive or responsive to pain, who have self-reported neck pain, or who have a concurrent substantial head injury or torso injury. Again, you consider X-rays for those kids, although I think you could be warranted to do a CT as well. And then outside of those groups, clinical clearance may be sufficient. An example of a high-grade cervical spine trauma. This is a 15-year-old who dove into a pool, hitting their head. And so we have a burst fracture of C5. I think you can see some retrograde positioning of C5 with impingement on the spinal canal. The axial image shows us that burst fracture again, as well as actually a fracture involving the posterior elements. So a high-grade trauma. We have guidance from PCARN for abdominal trauma imaging as well. As these studies tend to be, this is a very large study involving 12,000 children and 20 emergency departments throughout the US and Canada. And this is a guideline that's really intended to identify patients who are very, very low risk, who don't need imaging. So this definitely drives patients towards CT when they have a fairly low risk of injury, but we want to be cautious and not miss anything that would need intervention. So it's a balance, of radiating those who might not need it versus catching injuries that need to be treated. So similarly to the head and C-spine imaging, there's clinical evaluation that forms these decision points. Evidence of abdominal wall trauma or seatbelt sign or a GCS score less than 14, those would warrant CT. There's about a little over a 5% risk of finding an injury that needs intervention. If you don't have those things, but the patient does have abdominal tenderness, then you would, again, do CT with a little over 1% chance of finding something needing intervention. Moving on, if they don't have either of those abdominal signs or symptoms, you would look for thoracic wall trauma or complaints of abdominal pain, decreased breath sounds, and vomiting, which many patients in ED have those. And it's hard to imagine having a traumatic injury and not having any of those. So any of those very, very non-specific complaints will also warrant CT. So we're selecting a very low risk population where there's only 0.1% of finding an injury that needs intervention. That's the population who can be safely evaluated and discharged without CT. It is also worth considering that you can use ultrasound in abdominal trauma. So a FAST, or a focused assessment with sonography for trauma, can be a helpful decision-making tool. If the FAST shows no intra-abdominal fluid, no pleural fluid, there's a very, very, very small chance you would need abdominal surgery. So almost negligible chance of needing surgery. So that may also help steer people away from doing CT in low yield cases. And this is an example of a kid who did have a higher grade injury, a higher level injury severity, and went on to abdominal CT. So we see a large laceration in the liver involving almost the entire right lobe of the liver, as well as some hemorrhage in the peritoneum. Aside from the PCARN guidance, which is fairly freely available online, there are also clinical pathways that many children's hospitals have published free and online. Ours at CHOP are available at this website, or you just search CHOP clinical pathways. And there's guidance for how you would use imaging and how you would clinically assess kids with head trauma. There's actually hundreds of pathways here, but that can be another source for information about how to proceed with an imaging workup in a trauma case. The American College of Radiology has guidance as well that really steers us more towards, which imaging is most appropriate. And why are we so selective about imaging? As I mentioned earlier, we try to minimize radiation in children because of that long-term risk that they could develop cancer from these ionizing radiation events in their DNA. So the best thing we can do is to, besides not doing CT, is to carefully select the field of view that you're going to use. So we see this most often in chest imaging, chest CT. When you do a chest CT, you want to see the chest and not necessarily the skull base or the abdomen too much. So being careful with the field of view. And then another thing that we do in pediatric imaging is we have a lot more tolerance for noisy and kind of poor quality images. This head CT here, which I showed you earlier on the infant, has a lot of kind of grainy appearance to it, like it's very speckly. And that's a characteristic of lower dose exams. You can see, for example, the wall of the lateral ventricle is a little fuzzy looking because it's so speckly. So that speckly appearance relates to a lower dose study. We also can use size-based protocols. So the beam energy, which is the kilovolt potential that we're giving in the X-ray, can be much lower in infants and small children. The KV that we use depends on the thickness of the tissue we're trying to get through, and so you certainly don't need the same amount of beam strength for an infant who is, got a very small body thickness that you would need in an adult who has a thicker body. The radiation is proportional to the square of the beam energy, so if you decrease your beam strength by a factor of 2, you'll decrease your radiation by a factor of 4. So that's an important way to save radiation in children. The protocols that you would use, I wish we could just give, a step-by-step instruction on which protocols to use, but it really does depend on the type of scanner. CT scanners have a lot of dose modulation built into them, and so different manufacturers have different types of dose modulation. Depending on how old the scanner is, it may have more or less of that modulation. So the best thing you can do is to use dose monitoring software so that you're at least aware of the doses that you're giving. There are some published average doses, so you can use those as a guidance for whether you're on track with your pediatric doses. The dose monitoring software will also allow you to make sure that you're not varying too much in your doses. So you want to kind of give a consistent dose each time. Okay. The other thing that I'm going to say, just the last thing before we move on to some cases, is that when you look at your CT techniques for trauma, doing a single phase, so with contrast only, is very, very rare in pediatrics that you would do a without contrast CT in the body. In the head, you do not use contrast for trauma, but in the body, often people will do multiple phases of contrast, which means multiple scans. So in children, it's safe to do a with contrast phase only. The non-contrast is typically not needed. Sometimes we do want to look at the circulation in more than just one phase, however. So typically our CTs are done in a portal venous phase, which allows us some arterial enhancement, as well as the portal venous phase, which sort of makes sure that the organs are fully opacified. However, we may want to look at a later phase as well. When we're looking at kidneys, suspecting any renal injury, we want to see if there's any injury to the collecting systems. And you can't do that in an earlier phase imaging. You have to have a late phase. What we do at CHOP and many pediatric places do is to split the bolus. And so you can give half of your contrast and then wait about 5 minutes for it to get to the renal excretory phase, and then give the other half of the contrast and then scan. And so that sort of gives you 2 different phases in one scan. So saving a full dose of radiation. CT angiogram is typically only done when there's known or suspected vascular injury. And we see that more often as a primary scan when there's extremity trauma, or we may have to do an angiogram if there's been documented vascular injury on an earlier scan. So, any questions about those before we move on to cases?
I have a question.
Yeah.
So, there's lots of protocols and pathways, but if you had to summarize it in a quick and dirty way of, who to scan, who not to scan, how can we identify those individuals if we don't have access to the protocols or know about them?
Yeah, so for the pathways, I think that the PCARN guidelines are reliable because they're such large studies. So, and those are available online freely. So you can find those and keep them sort of by you so that you know what the evidence is on who needs scans and who doesn't. So that's what I would recommend as far as determining which pathway to use. Regarding protocols that you might use for CT scanning, those are typically going to be programmed into the machines, ideally. And so having a pediatric trauma abdomen protocol already in the machine is helpful, because then the technologist, whoever's running the scanner, can just select a protocol that's already built in, as opposed to having to make one according to guidelines at the time. Does that answer your question?
Yes, thank you.
All right. So these are some cases people can take. I've got, 15 or so cases, and about half of them are for you to take. And then I figured we'll run out of time, so the other ones we'll go through. I'll show you some findings. Does anybody want to take this case? Sounds like no. I don't mind going through it. I know it's difficult when we're all virtual, and so this injury is not subtle. This 3-year-old fell down the stairs, and we have trauma to the left frontal area. So non-displaced fracture through both cortices of the skull, and then a small fragment that's displaced intracranially along with some gas. And I show this because facial trauma in kids tends to be at the frontal bone, whereas in adults, you are more likely to have mid-face trauma. Think about how many adults you see with zygomatic arch fractures. Adults have a much bigger mid-face, and so they tend to get trauma at the zygomatic arches, whereas children have a small mid-face and a larger head. Children are much more top-heavy, and they're much more likely to have trauma affecting the superior orbital rim. It can be very subtle, like this hairline fracture here, this non-displaced fracture that goes through both the cortices. So it's important when you have a facial trauma in a child to make sure to pay attention to the superior orbital rim and the frontal bone, because you can have some difficult to detect fractures there. This is less difficult to detect with the air in the skull as well, air intracranially as well. Soft tissues can help you. So you see the soft tissue swelling here. If you're not sure where the point of trauma was, if you're a surgeon or an ER doc, you probably can tell from looking at the patient. But those of us in radiology who aren't necessarily seeing the patient with our own eyes, look at the soft tissues to help you know where to focus your attention when you're looking for injury. And so here we have the fracture, which is a place that children are susceptible to injury. This 9-year-old was in a car accident. I would say like maybe 75% of our trauma cases are motor vehicle related. So I'm assuming no one wants to take this case. It's a little bit trickier than the last case, but I'm showing you a sagittal CT, and we see some hyperattenuation where it shouldn't be down at the skull base. So it's very important to evaluate the foramen magnum and the skull base cisterns, because hemorrhage in that area can be very concerning and very dangerous. So here we have some hyperattenuation that's just along the clivus here, as well as some suprasellar hyperattenuation, suggesting that there's blood products as well in the suprasellar cistern. So this is a dangerous area for a hematoma, which may compress the brainstem. It's also an area that's easy to overlook if you're not looking specifically at that area. We have hyperattenuation here showing the suprasellar hemorrhage. So just make sure that you always check this location. It can be a bit of a blind spot for sometimes.
Clinically, how would this patient present? And then what do we do for this patient?
So clinically, I think it's helpful to think about the severity score, the injury severity score, or the trauma level. So this injury is typically going to be a higher severity mechanism. So a high severity mechanism should lead you to look more carefully at the skull base. It does happen sometimes also that patients are susceptible. They may have an underlying collagen vascular disorder or something where their vessels may be prone to injury. So I wouldn't not look there in lower injury, lower severity mechanisms. But generally, it's going to be a higher severity mechanism that would make you want to focus your attention there. As far as how they present clinically, there can be neurologic signs, numbness, tingling, because this blood will coat the nerves coming out of the neural foramina of the spine. So you may have some upper extremity, especially numbness and tingling, which is a very non-specific sign, right? Because people who are anxious also get upper extremity tingling and numbness. So generally, I would, as a radiologist, not really evaluating patients frontline like some of you are doing. I would say that the injury severity score would be the most important factor. Does anyone else have thoughts on that who maybe has seen some of these cases clinically? Okay. All right. Here we have a 6-month-old who is lethargic. So not a lot of history, just a baby who's not doing much. And we see a lot going on in the head here. So we have hemorrhage, we have some hypoattenuation. In this 6-month-old, this was found to be child abuse. So this is some very severe intracranial injury as a result of that abuse. In this kid, we have subdural hemorrhage, you see here along the falx. So intracranial hemorrhage is one of the signs that or one of the findings that you'll have with child abuse. Classic signs would be having subdurals of differing ages, which is not what we have here. This is an acute subdural. You can have subarachnoid blood. You can also have diffuse axonal injury from the shaking that often underlies some of these intracranial injuries. Diffuse axonal injury can be difficult to see with CT, but it's usually accompanied by subdural and subarachnoid, which are easier to see. In this case, we actually have even more injury. There are infarcts, those hypoattenuating kind of darker features that are bilateral. In this case, we see them in the parietal and occipital regions. And that bilateral, fairly symmetric hypoattenuation is a sign of global hypoxia. That may be as a result of cardiac arrest. It may be as a result of a respiratory arrest. Or it may be as a result of intracranial mass effect. If there's swelling of the brain, that can occlude the incoming blood flow. So very concerning when you see hypoattenuation bilaterally. It's important to look at the cortex and sort of like the white matter of the brain together, because infants are not fully myelinated. So we rely on that sort of gray-white differentiation. Usually the cortex is a little bit brighter and the white matter, like most of the parenchyma, is a little darker. But in infants who are not yet fully myelinated, that gray-white can be harder to see. So when you're looking at head CT in an infant, sometimes it may look dark compared to what you expect to see in adults. So it's important to assess the extent of that feature. Does it go all the way down, all the way to the outer cortex? If you see something like this child definitely needs a skeletal survey X-ray series to further characterize other injuries they may have. So these are some injuries you might see on a skeletal survey. You would be looking for fractures. Rib fractures are one of the most common and also one of the most specific signs of child abuse. Fractures of varied ages is something characteristic of child abuse. So we see here in the right ribs that there are some fractures shown by the arrows, and there's callus formation. So there's new bone forming around those fractures. That process takes several weeks. On the left, with the longer arrow, we see an acute fracture. So no healing changes yet. So that's a sign of ongoing injury in this child. We also see pleural fluid. And not every case of rib fractures has pleural fluid, but in an infant, when you see pleural fluid on the X-rays, look very carefully for rib fractures. In children who are less than 2 years old, aligned posterior rib fractures are 95% predictive of abuse. Occult fractures, which are non-displaced and maybe hard to see on the first X-rays, can show up 2 weeks later on follow-up X-ray imaging. You may also want to do abdominal CT in non-accidental trauma, and things that might lead you to do CT would be bruising on the abdomen, abdominal pain, or abnormal liver or pancreas enzymes if you're doing a blood draw. So this kid has an adrenal hemorrhage, which is very concerning. Adrenal hemorrhage tends to be a sign of a very high severity injury. It's difficult to get the adrenals to bleed outside of the neonatal period. So that's very concerning. And then we have a laceration here, which we're not seeing the entire extent of it, as well as some poor definition of the pancreas. This is an example of one of those lower dose pediatric CTs where you have a little bit of speckle artifact. I'm gonna keep moving because we have about 20 minutes left, but I don't want to not take your questions. So if you have any questions, please jump in. This is a 4-year-old who was hit by a car. So generally we do start with X-rays in the trauma bay. For us and for many hospitals, X-ray is sort of built into the trauma bay, so you can get images quickly. And I'll tell you, in this case, we actually don't see anything. So you use your search pattern, you look at all the important areas, you look at the bones. There's nothing here. And this kid did go on to CT because of the level of concern clinically. And we see a small pneumothorax on the right. So the teaching point I want to make here is that if you don't see a pneumothorax or a small abnormality on the X-ray, it's unlikely to change clinical management. So CTing kids just in case, because even though the X-ray looks normal, is very low yield. So the X-ray in children is typically a good screening tool. And again, I think we don't see that pneumothorax on the X-ray initially, and it didn't change management. This 17-year-old dove into a pool. No C-spine fracture this time, just a little bit of lucency here, a little bit of lucency here. And so these are signs of pneumomediastinum, which we can see when there's pressure changes. So diving into a pool is one mechanism that can give pressure changes. I mentioned this, this is not really a trauma case, but pneumomediastinum is often something that people rush to CT to evaluate further. And in children, there's no need for CT with a pneumomediastinum unless there is a history of a penetrating injury. Pneumomediastinum in children, even very extensive pneumomediastinum, this is a very small one, but very extensive pneumomediastinum still does not need CT. It self-resolves. So we see that lucency there. The mediastinum is very challenging in pediatrics, and I think it scares a lot of people who are used to adult imaging. So I try to describe it as you want the mediastinum, the thymus, which is the thing that makes this challenging. The thymus should be kind of sloping like a mountain. You want to kind of start and at the top and then widen as it goes down towards the heart. You should be concerned when the mediastinum looks more like a tree trunk. So we want mountains. Tree trunks should be concerning as a mediastinal contour. The thymus involutes gradually between 6 to 7 years old, so it sticks around for a while. It may rebound, but as far as affecting the mediastinal contour, it's usually kids who are under 6 or 7 years old. We see here that the thymus can actually extend out into the lung, sort of layering along the fissure here. The thymus doesn't necessarily obscure the lung markings behind it, so that helps us differentiate this as a thymus as opposed to something else in the lung. Danger signs you want to look for in the mediastinum include a wide superior mediastinum, like that tree trunk appearance, also a wide posterior mediastinum, which is going to appear as kind of a dense paravertebral line. I'll show you an example of that. Loss of the aortic silhouette, which is more of an adult or like adolescent maybe finding you would look for, because the thymus will obscure the aortic silhouette. And concerning features if you have left greater than right pleural fluid in a trauma case. So what does that look like? This 11-year-old was in a high-speed motor vehicle collision, a level 1 trauma. And so we have here, this is what I mean by the dense, wide paravertebral line. So this line here is the posterior mediastinum. So there's some space occupying process in the posterior mediastinum. What lives there? The aorta. So very concerning. And we have some fluid as well in the left pleural space. Again, very concerning for aortic injury. The mediastinum is a little difficult. The upper mediastinum is a little difficult to evaluate here because of the technique, the low lung volumes and the portable technique. But this would warrant a CT. So this kid did go to CT, and we do in fact see an aortic injury. So there's a transection or partial transection, a hole essentially in the aorta. The aortic rupture or transection usually tears at the ligamentum arteriosum, so the point of attachment, and results in posterior mediastinal fluid, blood products, as well as left pleural fluid. These cases often don't make it to the hospital. For those who do, there's about a 40 to 66% in hospital mortality. In 10 years, I've seen 2 of these cases reach the ER, and they're very concerning because clinically they can look well. Both cases that I saw had GCS of 15, and the kid was talking, conversational with the clinical teams. But on imaging, we can see that this kid is severely, severely injured. So we have a kind of a rule of thumb in radiology that you treat the patient, not the imaging. But this is one case where you want to actually treat the imaging and not the patient, because this is a severe injury and there's a small window of time to intervene. Other things that can rupture, the diaphragm can rupture in a high velocity trauma. Posterolateral left is the most common site of injury. This can be masked. So a small diaphragmatic tear can be blocked by the spleen, or on the right by the liver. So there may be a tear that doesn't appear until even years later. This is an 11-year-old who came in because of vomiting, and we see bowel in the chest cavity. Looking back 7 years later, there was nothing there, and there was no history of trauma when this kid first came in, but there was a remote trauma. So that can be a delayed appearance. These also can present with volvulus. So the stomach can herniate up into that defect, and that is a sort of a setup for mesenteroaxial gastric volvulus. So seeing a diaphragmatic defect and bowel herniating may be a time-sensitive emergency because there may be a volvulus that could be compromising the blood flow to the stomach. Moving on to solid organ injuries. So we use the grading scale from the American Association for Surgery and Trauma, the AAST grading scale, and these are also freely available online. There's injury scales for every body part you can think of. The liver is one that we use very commonly, since the liver is one of the more common places to get injury in the abdomen. And this helps decide, these scales help the clinicians decide whether the patient can be safely discharged, whether they should admit the patient to a general floor or to the ICU, or whether they need to go directly to the OR. And so the liver scale has 6 different categories. I will say they're all based on sort of length of injury, and use this with caution in small children because, a 3 centimeter laceration in an infant's liver may actually go the entire length of the entire thickness of their liver. So just be a little careful in applying these. You wouldn't want to apply them strictly in children because of the differences in body size. This is an example of a 10-year-old who was in a car accident with a grade 2 trauma. So the laceration is less than 10 centimeters, and this patient did not need any intervention. You'll find in general that in pediatrics, there's much, much less intervention for lacerations, for solid organ lacerations. This 4-year-old, however, was also in a car accident with a grade 5 injury. So here we see the left portal vein has actually been transected, and there's just free hemorrhage of blood and contrast leaking into that laceration. This kid had ongoing hemodynamic instability, and this is one of the rare cases in which there would be either surgical or endovascular intervention. Adrenal injury, as I mentioned earlier, is something to look carefully for because it's a sign of a high severity, high impact mechanism. And we're not always looking carefully at the adrenals. So do that, look at the adrenals. If you see an adrenal injury, look carefully for other injuries because they often are accompanied by other injury. This 6-year-old was in a car accident and had a right adrenal hemorrhage. When we look elsewhere, we see a burst fracture of the lumbar spine. So that's the case I showed earlier with multi-level vertebral compression. It's hard to appreciate on the CT exactly how many of the vertebrae are affected, but there's multi-level vertebral compression and some impingement on the spinal canal. So adrenal hemorrhage, look carefully for other injuries. Bowel injury can be very difficult to detect. So you want to look for small bubbles of free air, like you see with the thicker arrow here. Areas of abnormal enhancement. So the 2 thinner arrows are pointing to an area where there's more enhancement than there is other places in the bowel. So that can be a sign of a bowel injury, either a contusion to the wall or a laceration to the wall. And this star is showing us thickening of the transverse colon here, which is hard to appreciate on a still image. So and small bowel also that is kind of elongated and tubular should be concerning. We see a focal defect in the wall of the bowel here. These bowel injuries often accompany lap belt injury, so you look for signs of contusion in the abdomen that would suggest a seatbelt injury. So in this case, there's bowel injury and free air. The lap belt injuries can also affect the vessels, so you're usually getting very focal and high impact trauma in a very small range where the seatbelt is located. So in this case, we have laceration and intramural hematoma in both the SMA and in the aorta. We see in the spine that there's a chance fracture, which is another classic lap belt kind of injury. So you fracture through the posterior element of a vertebra. And there's, again, that intramural hematoma in the aorta. So lap belt injuries, you want to look sort of in that band of where the lap belt would affect the anatomy. And then the last case I want to show you is what hypoperfusion complex looks like on CT. This is shock. So hypoperfusion complex is when the body is sort of vasoconstricting and shunting blood away from non-critical structures. And sometimes we can see this on imaging before it's apparent clinically. So this is another one of those cases where you want to, as a radiologist, be in close contact with the clinical teams to let them know the patient may actually be doing much worse than they think. So in this case, this 4-year-old was in a motor vehicle collision. We see a small caliber aorta, which is characteristic of hypoperfusion. A flattened IVC. So the IVC, this is not as flat as they sometimes are. Sometimes it's very flat. Sometimes the aorta looks like the size of like a superficial femoral artery, like it's very, very small. So if you have a very small aorta, be very worried. There's also diffuse bowel wall thinning, dilation of the bowel. We don't always have dilation of the bowel like this, but the bowel wall is often hyperenhancing. You will also see in the solid organs what looks like a kind of an angiographic phase. So the vessels tend to be very bright because of that vasoconstriction. And the adrenals are again, like the adrenals can be the key to not missing subtle things. So the adrenals in hypoperfusion complex are brightly hyperenhancing, which normally they look the same kind of shade as the liver or the kidney and things around them. So when the adrenals are hyperenhancing, that's a sign that the kid is in shock. It could be hypovolemic shock from hemorrhage or cardiogenic shock. So that's up to clinicians to figure out why there's shock, but we in radiology can help them identify it early. So this can, cause precipitous hypotension within 10 minutes, emergent communication to the referring physician. I have about 8 minutes left. So in summary, there are guidelines. Typically, the PCARN guidelines are the ones that I use and I would recommend. There are other guidelines that are also useful, so it's not the only guidelines, but it's what I tend to use for when to use CT. If you're unsure, it's generally safer to scan. In a high velocity trauma, scanning should be the default. What we see often is that smaller hospitals that don't have as much specialized pediatric care or don't see as many pediatric patients tend to do more scanning, and I think that's probably safe. If you're unsure, it's safer to scan and not miss an injury. However, guidelines do exist for when it's appropriate to scan. There are important strategies you can use for lowering pediatric radiation, besides being selective about who gets a scan. Using smaller field of view, using a single phase rather than multiple phase scans, and using lower energy for smaller body sizes. In head trauma cases, make sure you assess for frontal fractures, which is where pediatric fractures are more likely to happen, and skull base hematomas. So look very carefully around the skull base. For chest trauma, CT is often not needed if the X-ray is normal and the patient is stable. You may find small findings, but they're not going to change management. And then finally, for abdominal trauma, pay attention to the adrenals. Look for hemorrhage, look for hyperenhancement and signs of shock. And bowel injury can be difficult to detect on CT, but look for irregularities such as thickening, focal enhancement, or gas around a bowel loop. So that's it.